Preparing to live stream, setting up the meeting. Redirecting to YouTube. And we are on YouTube with the first slide. Right. So never before any course was packed with these many pre-course webinars in a very short period of days. We had 6 webinars in the course of around 3 days. And attending this webinar itself is a painful procedure in itself. Okay. And of course, the pleasure of all the pre-course webinars, however they are conducted, when the pre-course webinar is by and is for the theoretical background, the principles, which everyone as a participant who is traditionally conditioned, okay, they always prefer some kind of study material where we give this lecture handouts as the reference study material. So madam's presentation today will be the Google Drive link where you can download, okay, so that you can access and with the theoretical content, because if you are happy to see the printed content, okay, there are a lot of people who recommend that something printed content will always be better, it will be better, whether it is a hard copy printed or at least something text, okay. So for different type of learners, okay, so and most importantly, when Ritu presents, the presentations are always very, very colorful, attractive, comprehensive, simplified, and extempore presentation. So we are also eager to listen to Ritu Sahni ma'am when she will take now on the mechanism based perspective, the AOMPT's perspective on the pain. Okay. So the presentation is loaded and ready. We will now move on to it when the Zoom recording also will be starting. Yes, ma'am.
Yes, sir.
Yes.
Good evening, sir, and good evening all the participants who all are enrolled for this webinar, this workshop that is on coming Saturday on the pain-based mechanism. As we are learning from last 2 days, we are as a pre-congress webinar till today 5. We have finished with our webinar number 6 for the pain-based mechanism. And we have covered all the components related to the cognitive, affective, psychosocial, and as well as the central sensitization, nociception, where articular versus the myofascial differentiation that we have covered till now. But now today it's just a presentation about that the revision of the content which we are going to see as a practical demonstration from sir side in the workshop as a offline versus the online, both the mode. So you can see that these flyers, why I have kept these flyers on the screen, that yes, it is not a new for the AMPD that we are working on the pain mechanism or the nociception specialist courses, because we are learning from last 3 years, and AMPT is the academy who focus on the patient centered approach, who focus on the patient centered understanding of the pain by learning through the pain based mechanism. Because I have seen in the PubMed that there are so many articles which are published by Dr. Senthil sir, and these articles were very, very patient centered, and these were focused on the pain based mechanism. Whatever the condition the patient is having, either they are having a articular problem, myofascial, or the visceral problem like the cancer pain itself. So how, or the old age patient, how we can handle according to the pain based mechanism, or how we can improve the gait with the pain based mechanism. So these are the nociplastic pain neuroscience education. These are all are the part of the AMPT from the starting onwards. But as the people join the AMPT, they are becoming the part as per their convenience, as per their time, and when what their destiny is given them the time to join the AMPTs. But we are still in the last year or the previous sir presentation, we can see on the YouTube video links where the sir has provided the full knowledge about the pain based mechanism. So these are the things which we are working on the patient centered approach, and today is the day for our the theoretical part of these mechanism, how we can move in one by one so that we can easily understand the patient behavior, their history telling, their evaluation, that how, in which category we are keeping the patient. Either they need a treatment related to the central sensitization, or they need the treatment related to the cognitive effective according to their emotional nature, their emotional demand, that how we can understand them. And as per the, if we are talking about the musculoskeleton, so how articular myofascial versus the neuropathic pain, and how the central sensitization versus the peripheral sensitization plays a major role, and as well as autonomic nervous system, which is also a very important part of our treatment. So by these things we are going to see one by one. And already in last 2 days, sir has given a very much light on these content, but today also we will revise so that we will be ready for the Saturday workshop, where we will see as a practical demonstration, and the participants who are joined just the AMPT, they can understand that what kind of the study material. These webinars are the study material which you can anytime, anywhere you can see, and you can listen, and you can feel that, yes, by this, if I am confused with this kind of the patient, so how I can come out according to the these guidance which is provided by the sir. So welcome you all once again, and we are moving towards our presentation. That is the science of the pain, how we understand the pain, by like in the previous session itself on Instagram, that sir has explained that how we understand by taking the evaluation history related to the musculoskeleton, the nociceptive fibers, articular versus the myofascial, and with the differentiation between the neurogenic pain or the neuropathic pain. So these things are very important. And in between also, we can add the treatment related to the central versus the cognitive by talking to the patient, by motivational interview, that gives us the idea that what kind of the thinking process is going in the patient brain when they are in the pain. And now we are talking about the 5 pain-based mechanisms, which are very important, like the cognitive affective, central sensitization, nociception, autonomic sympathetic mediated pain, and as well as the peripheral sensitization, where we see as the radicular pain, neuropathic pain, that is the cause of my patient pain. So these are the thing, central versus peripheral, because we can distribute the pain pattern from central brain to the peripheral, all the periphery region. And with the emotional aspect, or the patient is having a sympathetic mediated pain, where their sympathetic versus parasympathetic pain related autonomic nervous system give us the idea that how we can differentiate these kind of the pain according to the mechanism based reasoning of patient centered approach. So pain science education, it's a very important part where we learn that what is the pain science education, what is pain and how does it work in the body, or how can physical therapy help me with the chronic pain if I am having a pain. So this was our just before 10 minutes before that, sir has highlighted that how a physical therapist can understand about the pain with their component, with the articular myofascial and all the component related to the uh, by taking the history related to the where the need is central sensitization or the cognitive behavior. So this is the way pain science education gives us this idea. And I will say that either the people are learning from so many books, but what we are learning, that is only what AMPT is providing, that eye-opening pain-based mechanism, which is fully on the patient-centered approach. And we want to raise the functional recovery of the patient. That is our focus here. So that for that, whatever the good things we can add in our treatment, as we are not going to fill any form here, but yes, as a filling of the patient queries in our brain is the important part here. So that is our priority to learning about the pain science education. And in this also, we neurophysiology, we understand that neurophysiology of pain, which is the pathways of the nociception and the nociception pathways, and how the neurons, their synapse plays a very major role. And after that, how the action potential of these nerves comes with the either the spinal, is there is a inhibition signal or the facilitation signal related to the pain. Either they are giving the signal to feel less pain versus the more pain. It's according to the peripheral sensitization versus the central sensitization, and as well as the plasticity of the nervous system, how our brain adopt the neuroplasticity, how our brain feed the information in brain, that if like the removal of the thumb or removal of the hand. So how these memories, the images are occupied in the brain. So these are also the training through the brain gym is also very important part of the pain neuroscience education, because if we will not treat the brain, we cannot treat the musculoskeletal disorder, like the patient who are having a stroke, who are having a Parkinson disease. In that, the brain gym exercises or brain gym based treatment is very important, so that we can revise them, that these activities they were doing previously, that can give them a better way to improve their functional activity. So this is the way we have to train the nervous system if we want to train the musculoskeletal disorder or whatever the component is the patient is not able to do their functional activity. So training through the brain is very, very important, because the neurophysiology of the pain that sends the signal to the brain, and then again the signals come to the body to complete their cycle of the working. So if warning pain, where is the pain coming from? Yes, this is the also a very important part. Yes, either the muscles are in the, because of the muscle the patient is having a pain, ligaments, nerve, joint, disc, whatever the structures in the body, in which part the patient is having a pain. So this is the warning pain, which when the patient comes, they say that yes, I am having a pain, that I am not able to hold anything. My grasping power is less. So that why this grasping power is less, because of the joint. There is a no extension, or the pronation supination is restricted, or either the muscle contraction like the force closure active versus the passive stability is compromising, or the neural component which nerve is supplying to that particular muscle, so that muscle is the cause of my patient pain. So these things, or the vascular system, either the venous versus the arterial system, that can be in the compromising state. So the patient is having feeling a heaviness versus lightness in that limb. So they are having the effect of the gripping, or the patient is having any visceral problems. Because of that, they are with viscerosomatic problem is there, so that the patient is not able to grasp that thing. So these are the things, where is the pain is coming from, is my first part to see that which component I have to work and how we are going to evaluate it. So this is all when the patient is having a pain. There are so many factors which influence them, like the biological factors, social factor also, and the patient, they are having with the sleep disturbances, their mood swings are also coming, and that will also alter their activity when they are having in the anxiety, they are not able to perform their work. So the lack of energy make it hard to be active. So there, it means their energy with the pain drains, which is draining the energy when they are having a pain. So this is all the vice versa, or I will say that reciprocation is going on, that one by one these things are adding in the sequence, either the biological factor or the social factor, which can be the cause of my patient pain, or the psychological factor. So these things, either any trauma, any injury, or any childhood memory which is not allowing them to be come out from that thinking process, or their these things are impacting on their brain, or their economic factors, social support, spirituality. So these things are also causing the pain. So understanding of pain in this factor, biological, psychosocial, or social factor, psychological and social factor, these are also important part as a cognitive effective behavior of the patient, and as well as the central sensitization. And now we are moving towards our main focus, that on 5 mechanism, where we are going to see one by one is the cognitive affective, central sensitization, and sympathetically mediated pain versus peripheral and the nociceptive pain. In this also, observation is a very, very important part here. The observation of the posture and the functional activity, which is the patient is not able to perform their activity, like the static posture, dynamic posture, and the functional posture. So these are important link which we see when we understand about the pain mechanism. And then we do the movement testing. That is also important part. That is the differentiation based movement testing according to the component arthromyoneural differentiation. Because if the patient is having an articular problem, so there is a compensation is taken by the muscles, and the neural component is also in the chain. So we cannot separate them, which we have already discussed just before 20 minutes before. And the regional interdependence that also plays a major role in the structural versus the functional approach of the patient, and the functional where the kinetic or kinematic part plays an important role. Whenever we gives the treatment, we see that the what kind of the treatment we can provide for the kinetic versus the kinematic, where the joints versus the muscle activity, active and passive, both the structures can be in the picture, with the force versus the form closure, and with the active versus the passive structures, which we have to increase their range of motion so that my patient can be do their better functional activity. And palpation is also important part here on the local finding, the temperature, because we can see that the skin texture, by that we can differentiate that either the patient is having any autonomic disturbances. So we see the temperature, tenderness, tissue texture, that also plays a major role, because or the tissue tensibility, because we if we want to give any therapy related to any urgents we want to give them, like the ISTM or the cupping, or we want to treat the fascia. So these palpation local finding is also important part of my patient pain, where the temperature, tenderness, and the tissue texture gives us the idea where I can treat or where I will not treat. So that is also very focused line of treatment. By the palpation, we check and we see that how the skin, the texture of that particular tissues are responding to my treatment. And when we see that the types of the pain in also like pain-based mechanism, we have seen the 5, but there is a types of pain where we divide the somatic pain, that is the superficial versus deep. Superficial means the skin, where the pin and prick, pinching, scraping the patient feel, and the deep like the connective tissue, bone, joint, and muscle, with the arthritis, muscle cramps, and the bone structure. And again, the neuropathic versus the visceral, where the kidney, gastric torsion, or all the visceral organs can be the cause of my patient pain, either the acute or the chronic. So first we are moving towards the cognitive affective, that is important part. Yes, here the emotional affective, we can see that this is the emotional affective, and it is a multi-dimensional experience. Different components interact from the complex nature of the pain. Their reciprocal relationship are indicated, like if the patient is having a emotionally effective, so it means there is a cognitive behavior, so that the patient can be, they can give so many excuse to you that yes, this is the cause, this is the cause, and they cannot remember what they are saying in these things. So they can be uh, nociceptive also, or there is a nociceptive sensory problem also. So they feel pain, sudden pain, and the diversion of their brain, they will not feel any pain. So this is the emotional effectiveness is the major part of the cognitive effective uh, characters. So we whenever we see the patient who are in a hurry always, and who want only treatment, and they don't want to discuss anything about their case history, so they divert your brain also, as well as they want to diversion of their brain also. When somebody is passing through with them, so they will take the see them back, that time they will not feel any pain. But again, when they will turn and they will see that you are checking their hand, they will again feel the pain. So it means the diversion of the brain is very, very important part, and this is the characters of their problem, that the diversion can change their pain pattern. Also the diversion of their brain or their sight can also be increase their range of motion of that joint also. Even you can check the tenderness, you can check the joint mobility when their mind is from another side and they are seeing to another side. So they, you can do the testing easily. So that is the typical behavior of the cognitive affective, which we can see by taking the history or evaluation itself. When the patient enters in the clinic, by their language and by their behavior, we can assess that yes, this is the patient where we need the counseling, where we need the psychological treatment they needed. So this is, we are not sending them there, but we are having also so many techniques by which we can train their brain, so that they can come out from these things, so that their diversion, which diversion was on towards the their pain, reducing the factor of the pain. So we can give them that by doing this activity, we can give them the exercise, so that they can do in a intermittent, they can do that exercise, and they will feel better in their functional recovery. So in this also, a depression or the pain increased depression interferes with the sleep also. So depression beliefs, they feel that yes, they are in the depression, they are sad, nobody is there for their help, so they feel loneliness, and these kind of behavior, they show that they want their the center point of attraction they want. So somebody, if somebody give them a more attention, they feel so much happy. But if somebody ignore them, they feel, oh, no, 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 my life is nothing. So these kind of behavior, they feel useless to them as themselves. So these things are the cognitive affective pain pattern. Because in this also, the emotional factors have a surprisingly important influence on the pain perception. So this is the very major or important point. And a negative expectation can completely reverse the analgesic effect of a clinical dose of the opioid. If their negative expectation, they can, the medicines which they are taking, it will also not work on that, because they are already, they have made their mind that yes, about themselves. Internally, they know that they are good, but if externally they see the people and their behavior, they see that no, 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 I don't want to live and my life is useless, like condition they feel. So it means that clinical and experimental studies show that even a simple psychological manipulation, such as a distraction, can have a powerful effect on our perception of the pain or for the cognitive affective. So it means that we have to be our treatment should be changing their view of for the life, so that they will not be in the depression. Because if they are not in the depression, their pain will not increase. They will adjust with this pain pattern, because now they are out of this. And when they are in depression, their fear of pain decrease activity, they cannot do their activity, and they will avoid the activity, and the fear of failure, it's always the part of their life. So they don't want to do anything, because they think that if I will do, I will be failed. So this kind of behavior not allow them to do their activity. So activity, when they avoid that activity, it makes the pain more worse, because they want to do from internally, but externally they are having a fear of fall or fear of any failure, so they are not doing. But these avoidance also making them in the depression, and these depression are giving them a more painful condition, all not only the central nervous system, peripheral also. So these kind of the all the picture we can assess with the patient behavior pattern. Yes, they are the patient where we keep the pain based mechanism in the cognitive affective pain. So in this also, we have we can understand that what is the input, that is the external, and what is the output, that is the behavior. The cognitive psychology say that how the behavior they show. So in this also, this is the mechanism where thought versus emotion versus behavior, these are the triangles, and they are in the reverse proportion. Either the behavior can be the cause of their behavior, or behavior can be the cause of their thought, or the thought can be the cause of their behavior. So this is all the triangular situation they feel, and they are very over expressive, catastrophizing. They're because they want to do so many things, but they feel they are useless. So these kind of situation give them attack in their brain. Emotionally very unstable, and externally locus of control. So externally locus of control, internally they want that they can do, but externally they are having a fear that they cannot do. So this kind of locus of control is also the part fear. Because of that, there is a fear of avoidance, and they are always in the hurry. They will say, I don't have a time, please listen it, please do it my work first. They always want the priority. So they, because they show that they are very busy, and please finish their work and then do any other work. And the one more point, that is the kinesiophobia. They feel that I will, the movement, whatever the movement, I functional activity I will be doing, it will hurt me, I will fall. The fear of fall is always in their brain, and they always show the non-organic sign, not the organic pain they are having. They are having the non-organic sign. So this is the typical characters of the cognitive affective, where we have to work on the cognitive affective mechanism. That is the important part of our one first pain based mechanism, where we now clear with the cognitive affective mechanism. So in this, there are so many things. What causes the catastrophizing? Anxiety, depression, fatigue, chronic pain, insomnia, post-traumatic stress disorder. So these are the causes which, and they will, if the pain intensity is more higher, that also give them the anxiety, depression, like the condition of the catastrophizing, and this catastrophizing is taking them into the health anxiety and the kinesiophobia, to the fear of the fall. And locus of control will be they are having in the external locus of control. Why me? I never get what I deserve, not my mistake. So these kind of the situation comes in their mind. So this is the way we can understand the cognitive behavior and the pain experience. If there is an injury, they are having any pain experience, so that pain can be also catastrophizing, fear of movement, avoidance, and the diffuse and disability which causes because of the depression. So these are the things. They are people with the maladaptive daydreams often lose touch with reality. They don't want to see the reality. They always want to listen what they want. If they want to listen uh, their the wrong image what they want they made, so they want to listen only that. They don't want to listen the real, the truth, the reality. And they are having a poor social skills. So they don't want to interact with anyone. They feel shy, they feel emotionally uh, depressed, so they don't want to interact with anybody. They just keep their mouth shut. And when they want to speak, they speak that according to their priority. So these kind of the behavior, these are all comes in the mechanism of the cognitive affective mechanism. And in this also, one point we have added here in the cognitive affective mechanism, that is psychosomatic pain. So what is the psychosomatic pain? That is from the psycho means mind, and the soma means the body. So the pain or the mind is like the patient is having a pain in the their any body part, and that is related to that brain, because there is a some history or previous injury, any back pain. So these things are just captured in their brain part. So they, whenever they see any condition or whenever again they comes in that position, they feel the same pain. Either this time the pain will be less, but they feel the same, because their brain has adopted that capturing that picture, that yes, previously also you were having a pain. And the person who is in the TV or in the media or in the newspaper, they are having that pain, they will feel the same pain in their on body also. So the types of psychosomatic pain, where the headaches, if they see somebody is in the headache, they will feel same pain, the headache they will feel. Or sometimes the hot versus the cold weather change their body pain, either the back pain, abdominal pain, or one kind of the food has given them a stomach related pain, digestive pain. So again, if whenever they will see the pain, that food they will see, they will think that again if I will eat this food, I will be in the same problem, I will come. Either maybe this time it will not create any problem. Or the same, like there is a painful menstruation cycle. Sometimes we are having a more painful cycle, some less. But when the before the menstrual cycles are coming, the days before 3 or 4, we have starting that brain has giving started the signal that yes, again this time I will feel more cramps, I will feel the pain. Oh, these days I will be not able to perform my activity, my days are bad. So these kind of the things they capture in their brain and mind. So again, if there will be no problem, but when they think, they will feel again the same pain. So these kind of the psychosomatic pain is also the cause of pain based mechanism, where we cannot ignore these kind of mechanism also. And this is also, in this there are some symptoms which is also known as the psychogenic pain, or the pain disorder caused by the psychological stress or anxiety, and the chronic pain in more in one area and last from the months to years. So these kind of the pain, because they are taken a MRI in their brain for that pain, so that cannot be easily vanished from their brain. So these type of pain cannot be explained by the medical condition, and the start maintenance, or it can increase in the severity of the symptom and caused by the psychological factor. So in this also you can see that if there is a back pain, it's more agitated with the stress, or stress agitated the back pain, these kind of situation. Or if they want to good physical health, immune system works better, they feel relaxed. Or when they are relaxed, their immune system works better. So these kind of the cycle also comes in their brain according to their convenient, or according to their assumptions, that if they are feeling stressed, they will feel more stressed. If they feel relaxed, they will feel more relaxed. This kind of the condition is the psychosomatic pain. So we have to see these things also very important part of the pain-based mechanism. And now the next is the central sensitization, the case study of second, where the first we have seen the cognitive affective, where the patient, they want attention, they are in the very hurry, they want to give them, they want that everybody has to give them the priority. But now the central sensitization, where the patient is having symptoms are little different from the cognitive affective. There the constant pain, high severity and high irritability, chronic and recurrent pain, disproportionate symptom, exaggeration, diffuse non-anatomic, like a hide and seek symptoms with a local physical appearance, mechanically provoked or aggravated pain, hyperalgesia or allodynia, which can be with the tactile, brush evoked, thermal, any touch which is non-stimulus can create the pain, and the sleep disturbances, fatigue with the low energy level. So these are the characteristics we see in the central sensitization. Where the cognitive affective, we have seen that how the lack of time, over expressive, they want attention, and there the pain may be high severity or high irritability. So, and it can be chronic or recurrent, and it can be diffuse non-anatomic pain with the symptoms hide and seek, that sometimes they are feeling more pain, sometimes less, sometimes they feel their symptoms are on high side, or they can be mechanically provoked or aggregating. And the hyperalgesia versus the allodynia, where the non-stimulation stimuli pain creates the pain. So these kind of condition, and they are in the hyper pain. So these are also, because of that, they are having the sleep disturbances. That type of symptoms we can see with the central sensitization cases, when the patient is having these kind of symptoms. In this also, because there is a, we are talking about the central sensitization, so understanding of peripheral versus the central sensitization, how the brain and the peripheral nervous system, they are getting the signals with the nerve, that they are taking the signals to the brain, that that area the patient is having the pain, like with the free nerve endings, they are carrying the signals, the sensory fibers going, and after that the motor signals are coming, and then the muscles and the joint, they are doing the their activity. So these, the central nervous system versus the peripheral nervous system, they both plays a very major role as a peripheral versus the central sensitization, where we know that the spinal cord versus the brain, which give the signals to the central nervous system, and the peripheral, all the periphery nerves which are, and the free nerve endings that are sending the signals to the peripheral nervous system. So one first is the central sensitization. It is also defined as an increased responsiveness of nociceptors in the central nervous system to either normal or subthreshold efferent input, resulting in hypersensitivity to stimuli, responsiveness to non-noxious stimuli, and increased pain response evoked by the stimuli outside the area of injury or an expanded receptive field. So in this central sensitization, increased activity in nociceptive facilitatory pathways, which activate the glia in the central nervous system, and the disrupted resting state functional connectivity in the default mode network, altered sensory processing in the brain, and the poor endogenous analgesia. So central sensitization here, hypersensitivity to the stimuli is the main character. Responsiveness to the non-nauseous stimuli is also a very important, which we characterized as a hyperalgesia or the allodynia, which is the main two characters which we see when the patient is having a central sensitization, where because of these hypersensitivity, all the nociceptive facilitatory paths increase their activity. So these kind, that how the central nervous system is the important part of the central sensitization, where all the activities which the patient wants to do are just, they are captured in their brain, either in their history, or so many years back, the activity which were feeded in their brain was causing the pain, can be the current cause of their pain. So in this also, that how if there is a injury, there is a surgery, inflammation, how the peripheral sensitization to the central sensitization, the pain message is going, and the pain cognitive process with the depression and activity, and again the whole of full cycle is going on with the pain cycle, and the patient who are more prone to stress are more likely to have a higher sensitivity to the pain also. In this central sensitization, it is also interfere with the say sometimes with the cognitive functions like memory and the concentration, and emotions like anxiety and the depression may also be highlighted if the central nervous system is sensitized. It means the patient who are having a cognitive affective problem, so there can be some matching with the central sensitization also, because here also some emotional factors and some anxiety, some depression is also feeded in their memory, so that can be also the cause of their pain. So in this also there are some way that to understand or to take the evaluation with the mirror therapy, which as a mirror therapy we use for the evaluation, and as a treatment part also to give the treatment for this central sensitization, where we treat the brain, we train the brain for their activity. Thus, this stimulated visual feedback activates their mirror neurons to the premotor cortex. This is the part of the brain that controls the movement. So this is the way we can see unaffected versus affected limb can be getting relief through these activity if the patient is having a central sensitization. So mirror therapy, brain gym, or the graded motor imagery, and as well as the left and right discrimination, these kind of treatment are very much suitable for the central sensitization or for the cognitive affective also. So these kind of mirror therapy, brain gym is always very useful whenever we see this kind of the patient who are having a stroke or the Parkinson, they are having related to these kind of situation where we can use this technique, and we can get better result when we train their brain. And then the peripheral sensitization mechanism, this is the case number 3, where the diffuse low back related, like, because first the central sensitization, then the peripheral sensitization, we are working on the peripheral part, because centrally we have seen that how the spinal cord and the brain was in the picture when the patient is having a pain related to the central sensitization. But when the peripheral, because we are talking about the periphery, either the upper limb or the lower limb, and the neural component in all over the body. So diffuse, like the diffuse low back related leg pain, dermatomal distribution of the pain, mechanically provoked or aggravated, shooting pain, pins and needles, tingling, numbness with or without sensory motor or reflex dysfunction, positive slump test, tenderness on palpation, either for the upper limb or the lower limb, like for the sciatic nerve or for the median nerve on the upper limb, and the positive tunnel size. So these are the mechanism which we use for the peripheral sensitization. And in this also, that peripheral sensitization, how we check when we see the patient by their proximal versus the distal part, how they are having the pain, their numbness, their tingling sensation. So these kind of like one of my patient whose picture I have captured here, that is the meralgia paresthetica. So how the patient feel the peripheralization, sensitization. So these kind of pictures come in our clinical view, that where we see this kind of the patient, they feel in their peripheral part the pain sensation is going in all over the peripheral, either for the upper limb or for the lower limb. So this is also that how the central sensitization versus the peripheral sensitization, they both plays the very major role for the cortical recognition. And in this central sensitization, taken we have focused on the two terms, which was the allodynia, pain experienced by a normal stimuli, and the hyperalgesia, when a painful stimuli is perceived as more painful than it should normally. Pain experienced by a normal stimuli. If I am having a like a allodynia situation, if I am just keeping my hand on my another hand and I am feeling the pain of my this hand, it means that is the condition like the allodynia. And if the when a painful stimuli is perceived as more painful, and if I have just folded and I am feeling so much pain, that is the hyperalgesia. So this kind of situation, how the non-painful stimuli can create your pain, or how the touch of only non-stimuli thing like the cotton or the feather, it only by when you keep on your skin you feel the pain. So this is completely based on the central sensitization, and both the terms are matched with the patient symptoms, allodynia and the hyperalgesia. So in this also, hyperalgesia and allodynia are the feature of psychological response to the pain, but can also be observed in the pathology. And it, like example, that neuropathic pain is characterized by the hyperalgesia, allodynia, and spontaneous firing of the nociceptor due to the nerve damage. If there is a nerve damage, the patient is having a neuropathic pain. So the same thing, these symptoms, they can be show while your evaluation, like the hyperalgesia and the allodynia, because they are having a spontaneous firing of nociceptors, the nerve endings. Because of that, they are feeling the hyperalgesia and the allodynia. These are the feature of the psychological response also. So in this also, how much is the injury, the patient feel more hyperalgesia, and the pain resulting with the normally painless stimuli, that is the allodynia. If the cotton can give me the pain, so it means that is the symptom of the allodynia. So by this you can see that the how the allodynia is a sensation of pain experienced in the response to the stimulus that was previously not painful. And allodynia is also observed in and around areas affected by the nauseous stimuli. So it means the feather can also, and the light touch can cause severe pain. So that is known as the tactile allodynia. So it is the painful non-nauseous stimulation can creating the pain. So you can understand about that allodynia, what is kind of the patient, if they are having a central sensitization versus they are having the peripheral sensitization where they are having a neuropathic pain. There also they feel this kind of, because of the nerve firing on that spontaneously area where the nerve is injured, nerve is in the damage. So that kind of symptoms also we can see as a allodynia. And then we are moving towards the nociceptive pain, which was the topic of our today Instagram webinar number 5, which sir has, I will say, explained in so much detail. So I don't think that there is a no need to explain in so much detail, because sir has cleared so many doubts that if the patient is having a nociceptive pain, that is due to the damage to the body tissues. So the patient feel sharp pain, throbbing pain, and because of any external injury as well as having any internal injury. And in this also the patient feel as a articular versus the myofascial component, they feel the pain. So how we do as a history taking evaluation, which sir has explained now, that how we can understand by taking the history, that if the patient is having a pain articular related with the hypo or hypermobility, so how, what is the history, that they are having a early morning stiffness, they are having a crepitus, and these sounds which can gives us the idea that there is a hyper or hypomobility. And if the patient is having a early morning stiffness, and after the doing some work, half an hour or 1 hour, they are feeling ease, so it means that is the articular component which are the cause of my patient pain. And if whole day the patient is doing their activity, and after that in the evening they feel tired, so it means there is a myofascial component, that muscles which are the active structures, they are now in the compromising stage, so they are not allowing the activity, or because the muscles are the active structure and they are now not allowing the mobility to the body. So it means there these are the muscles which are needs the treatment. So this is according to the nociceptive pain, articular versus the myofascial pain, where we see, which includes joint, muscle, skin, tendons, and bone, all the structures which are having a free nerve endings can be the cause of nociceptive pain, because we know that these nerve endings which are in the present in the skin, if my skin is injured, if there is an injury, there is a burn, so these nerve endings, they are sending the stimulation, they stimulate to the brain according to their neurons which are present there, as a slow versus the fast neurons which send the signals. That is also the fibers which are A delta and the C fibers, fast and the slow. According to that, that stimulation go. And we know that whenever we see that there the nociception, or there are nociceptors, mechanoreceptors, they are respond in the different, some respond with the light touch, some respond with the high touch. So their stimulation can give signals to the brain. So according to that, if which previously we have seen the hyperalgesia and allodynia. There also we see that how the touch can so much stimulation is sending the signal to the brain. With if I am not holding a tight, only with a light touch also they are sending the signal. So it means there are the receptors which are with the light touch activated, which are with the hard touch activated. So it means that nerve stimulation, the nerve fiber stimulation is important part of understanding of the nociceptive pain, because we know that these structures which are having a free nerve endings can be the cause of the tissue damage when there is a tissue damage. So these things, that's why whenever we use any treatment as a manual therapy, as a adjuncts, the cupping, IESTM, so that time we work on these nociceptors, we work on this the damaged tissue. So how we, when we give the pressure superficial versus deep or layer by layer, according to that how we talk with that adjuncts with the nerve ending. So these are the things. Now with the nociceptive pain, it is very clear to understand here. And this is also in the nociceptive pain, the nerve endings which are sending the pain signals, they can be mechanically provoked or aggravated. Flat, like as a articular part, the flattened lumbar lordosis can be in the observation, paraspinal tenderness on the palpation as a myofascial component. If the patient is having a restricted flexion, which is painful, and extension, which is less painful, then their range of motion restriction is there. Hypo or hypermobility, and reduce the muscle length as a muscle component with the hamstring, IT band, and the piriformis, which also sir has explained. If the patient is having a osteoarthritis of knee, the point main problem with the joint, but how these muscles which are having attached with that, they are having a trigger point tightness according to their mechanical versus neurophysiological dysfunction. So it means these their nerve free nerve endings are more sensitive. So these muscles, these joints, they can be hypermobility in the hypermobility, and the adjacent muscles can be tight, lengthening, shortening according to their this muscle dysfunction. So in this also reduce core muscle strength, because when the patient is having a mobility restriction, somehow their stability, the muscles which are providing the stability, can be the cause of their problem. So we are, as a patient centered approach, we are not only working on the one direction, we see the functional posture movement testing with stability versus the mobility, where we focus on the stabilizer versus the mobilizer also. So that is also the part of our treatment here. In this nociceptive pain, the causes are that is considered as the most common type of pain that stems from the injury. It caused by the detection of the nauseous or potentially harmful stimuli by nociceptor. For instance, the injury can be the bone, skin, muscle, and the other tissue. And this injury, not only the external, it can be the internal because of cancer, malignancy, or the tumor, or outer external where the bruises, broken skin, broken bone. So these are also is the cause of the nociception pain. And the components of nociception, where we check as a articular versus myofascial, which we have already discussed in our previous session, and the neural component, which also we check with the neurodynamic loading versus the offloading. So that is also, as a nociception, we see the articular and the myofascial, but as a, we cannot ignore the neural component. So that is also the part of our examination, which plays a very important role whenever we check all these components. And in this also, evaluation related to the somatic, cranial versus visceral evaluation is also very important, because the nerve, the tissue damage is not only the externally, sometimes there are tissues which are in the internal injury because of any visceral organ dysfunction. So because of that, the tissue damage is also there. So assessment of any history, any their surgery related or their post-operative history. So that also gives us idea that either the somatic, cranial, or visceral, which is the cause of my patient pain. As a nociception part of also the somatic and the visceral fibers are very important to clear all the way in the evaluation. And with the combination of the cranial, that is the added point of the AOMPT, which AOMPT take these things together, not others. I don't know about the others. They see that somatic versus visceral fibers, But in AMPT, we never leave the cranial alone, because sometimes the patient who are having a headache, the patient who is having a problem related to the flexion of cervical or extension of cervical, so their cranial related issues can be the cause of their somatic pain. The muscles are in the stiffness, the upper trapezius is in the tightness because of their cranium dysfunction. So these are the things we cannot leave as a nociception, that I will treat only the articular and myofascial, because in cranium, in visceral, there are also articular, myofascial, and neural components which we have to see and which we have to treat. And again, sometimes the nociceptive pain versus the neuropathic pain is also gives us the idea, either the both the directions are in the opposite side, but we have to be clear very, so that we can see that either the pain is described as the intermittent, or the pain described as
Muted.
the burning electric shock like, and or the shooting into leg, or the pain described as a crawling or unpleasant abnormal sensation like the dysesthesia pain, or with the other neurological symptom, and reports of the spontaneous pain and the paroxysmal pain. So this is also history of nerve injury, pathology, mechanical compromise at the region of the nerve root or the nerve tissue. But here with the nociceptive pain, there is pain described as a intermittent, antalgic, pain relieving posture movement pattern, clear, proportionate mechanical nature of pain with the aggravating and easing the factor, pain localized to the area of the dysfunction with or without referred pain. So these are the things which we clear with the nociceptive, with the neuropathic pain with their symptoms, that how what kind of the pain the patient feel. So that is also gives us the difference between the nociceptive versus the neuropathic pain. And the pathway of pain perception is also that how the nausea stimulation create when the patient is having any injury, the transduction at the peripheral nociceptors, where these free nerve endings, they are taking the with the first order neuron with the A delta, with the fast, and the slow is the C fiber, with the dorsal region, dorsal ramus ganglion, where the synapses is taking the place, and there the second order of the neural which takes the ascending part towards the spinal cord, that is the spinothalamic. From spine to the thalamus, they are taking these stimulation, these information to the brain, that the patient is having a tissue injury. And there also cortical side, there is a thalamus, and then they are having, there is a synapses is going on, and after that the descending modulation send the signal to that synapse place, where the patient is getting the stimulation, that how the pain, either they have to send the signals of the facilitatory or the inhibition of that pain. So this kind of the pathways of the pain perception, when there is a tissue damage is there, it happens through these mechanisms. And nociceptive pain can be further classified into visceral pain, somatic pain, and the radicular pain. This is also important when, like, we have just few days before we have covered our visceral manipulation course, where we have seen that the visceral pain can be felt when the pain receptors of or near the internal organs such as the pelvis, abdomen, chest, intestines are activated after an injury or damage caused to the internal organ. Its location is considered vague, as it is often hard to pinpoint the exact location of the visceral organ. So when the patient is having any visceral related problem, visceral organ, either the liver, gallbladder, whatever, or the diaphragm, the after the COVID diaphragmatic breathing is in the dysfunction. So the visceral pain, so that's why in AMPT, we are not treating the visceral organ, we treat as a viscerosomatic, because we know that the visceral dysfunction can impact on the somatic functioning also, like in the range of motion of upper limb versus the lower limb, or the even diaphragm itself can be the cause of range of motion of upper limb, and the pelvic diaphragm is the cause for the lower limb. So these are the things we cannot just take it, keep it as a separate. We have to think that we have to collect all this visceral to somatic, somatic to visceral pain, we have, which is classified here as a nociceptive pain, part of the nociceptive pain. So we have to understand that what is the relation, that if I am treating my patient the visceral part, how the somatic improvement is, musculoskeletal improvement is coming, how the range of motion is increasing, that kind of condition can give me the idea that visceral pain can be treated through the somatic, or somatic can be through the visceral pain. So this is the way we are learning in UMT, with the combination that how we check the regional interdependence, we check the range of motion restriction because of the visceral organ. So we give treatment to the visceral organ as a visceral manipulation or the viscerosomatic manual therapy. That is our focus on manual therapy, where we work on the visceral versus the somatic by we giving the keeping hand on the visceral, giving pressure on the visceral, and we check the range of motion of the musculoskeleton, somatic fibers of articular versus the myofascial. In this also, symptoms of visceral pain is often linked by the pressure, because we see that the keep our hand by giving the pressure itself, we can see if I'm giving the pressure on the diaphragm, the patient will feel uncomfort feeling is coming. So it means there is a problem related to the diaphragm, either the diaphragm need the doming or diaphragm need the release. So this is the part of our visceral manipulation. Itching, squeezing, cramping, these type of symptom, if the visceral organ related to the digestive organ, so their nausea or vomiting, that is also the part of their symptoms. And the change in body temperature, heart rate, blood pressure, these are because of if there is a diaphragm which is stuck in the dome shape, so how it will give the less space to the pericardium or the lungs. So because of that, the blood pressure, heart rate can be influenced as a regional interdependence. So these things also be the symptoms of the visceral pain. So that also we have to connect that either the viscerosomatic or somatovisceral can be by route of my treatment for my patient. And in this also, evaluation of visceral by keeping the hand on the viscera, and we can check the range of motion either for the upper limb or for the lower limbs, or for the pelvic treatment itself, if there the patient is having a prolapse or they are having a bladder related dysfunction. So this in this also by going through the viscera, giving the pressure versus the pain, check the pain versus pressure or the stretch, we can treat the visceral organ also with the somatic way, that by checking with the upper limb versus lower limb movement that can be affecting on that particular viscera, because the sharing of that viscera on that particular region or on that particular site can give us a right view for the treatment also. And then this is the somatic pain, which is also the nociceptive pain, originate from the activation of nociceptor that we have already discussed in our nociception point, that how these somatic fibers the patient is having also well localized in initial stage in opposition to the visceral pain. Like visceral pain, they are having intermittent pain, sometimes with the food, sometimes with the breathing, it alters, it aggravated, it relieving. So same time in the somatic pain, the patient is having the pain related to the bone, joints and connective tissues, with the after the fracture, after the injury, or the movement restrictions are there. So how we can deal as a somatic pain with their particular area where the tenderness is there, so how we can treat that, that is also as a somatic pain part. And the symptoms of also somatic pain is the cramping, gnawing, itching, and the sharp pain when the patient is having a any somatic pain. So as a muscular cramps, also as a myofascial component in the joints, they feel uh, hypomobility, dislocation, subluxation. So these are also the part of the somatic pain the patient feel. Or the joint misalignment, either the SI joint misalignment, because of that the patient is having, or the muscle strain, the hamstring tearing of that hamstring. So these are also part the patient is having, because of that the joint restriction is there. So this is the part of the symptoms of the somatic pain. And the types of somatic pain is also superficial pain or as well as the deep somatic pain. That is also as a two categories. We see that the patient is having either the skin mucus or mucous membrane, they are only the superficial injury is there, or the deep somatic pain occurs when the stimuli activate the pain receptors deeper in the body, such as the tendon, joints, and the muscle. So that time the patient feel the deep itching pain when the deep somatic pain, because of the stimuli activate the pain receptors, not on the superficial, they are going downwards to activate the stimulating the pain receptor, so the patient feel more pain. Because we know that the first order neurons in that their fibers There are fibers which are for the, some are for the low, taking like the C fibers, they are taking a low pain, and the A delta, that is with the, when they are stimulated, they get a high pain. So this kind of situation we see in the superficial pain versus the deep somatic pain. And there are some causes by which the somatic pain, as a bone fracture, muscles, fall, connective tissue damage, trauma of cut or skin. So these are, or the arthritis that leads to the swelling of the joint. So these are the causes of the somatic pain. And myofascial component, again, that we cannot treat as a single articular joint. We have to see that because of the uh, uh, articular part, if the joint is in not in a proper working, either hypermobility, instability, their stability and mobility is in the compromising state. So how that muscles which are attached to that joints can be the uh, in the cause of the pain because of myofascial pain. And in this also, how the mechanical, neurophysiological, and as well as the clinical symptoms of the pain, where the trigger point, tightness, lengthening, shortening as a mechanical part. And if there is a facial related adhesion contracture, the fascia is in the shortening, so that is the contracture. So there also we have to work on the myofascial component. We have to treat the manual therapy which is related to the myofascial component. So this is also, we are having a very big courses for this myofascial dysfunction, where we can take a deep, I will say, go into the ocean and we can learn about the myofascial component. This kind of courses the AMPT is having. Not only that one single course for the myofascial, there are myofascial release, fasciomuscular release, muscle energy technique, myokinetic chain, myokinetic therapy. So, or functional neurostabilization training. So these are the courses which can give us that if the patient is having a myofascial related nociceptive pain, so how we can treat them a better. Because if muscles are as an active structure, they are working in a right way, definitely they can improve the range of motion restrictions of the joint also. And by nurturing the nerves also can be very helpful when we give the muscle contraction and simultaneously thinking about the nerve which is supplying to that area, which is passing through that muscle, and keeping them in the treatment way, that gives a better result. That is the, I will say, glory of AMT, which we never leave any component alone. We take them together and treat them together. That is the orthomyoneuromanual therapy, the signature approach of AMT, that we always feel proud to use that technique on our patient. And the myofascial pain syndrome, we know that the deep itching pain in the muscle, trigger points, trigger knot, taut band. So these are the symptoms, the myofascial pain syndrome. So how we deal, that we have already discussed, that we are having all the technique related to the myofascial pain. We cannot leave our patient if they are having a myofascial pain, because we can either to the same muscle or to the opposite muscle, agonist versus antagonist, we treat our patient. We cannot leave them with a trigger point, we cannot leave them with the taut bend, and we cannot leave them with the difficulty in sleeping due to the myofascial pain. So we are having a huge uh, bucket or the basket for the myofascial component, and for the facial treatment, muscle versus the fascia treatment. And this is the formation, how the trigger points are the cause of my patient pain when there is a component of nociception, the myofascial component. So how these trigger point, it lies within the taut band, which is tight stand for the muscle, that the muscles are in the twitch response. So there is a taut band is coming. So in that taut band, there is a trigger point itself, the knot. So is it actually many nearby segments of the muscle fiber which is stuck in the contracted state. So that is the taut band. So there is a when muscle fibers, they are stuck in the contraction and they stop the blood flow to the area, stops. So that area muscle is not getting that proper oxygen. So these trigger points develop on that muscles and all around the any other muscles also, like the active trigger point versus the latent trigger point. So these trigger point can also be tricky, that can create a more pain when we do the palpation, we keep our hands, so the jump sign, referred pain. So these criteria gives us the idea that there is a taut band, and in that taut band there is a trigger point. So how we have to release that trigger point as a myofascial component is the important part here. So to release the trigger point as a active trigger point, or either the latent trigger point, which are already in the sleeping position, but when we give activate the muscle, so that we have to check that either only the active trigger points are there or the latent trigger point also there. So these kind of, they create a referred pain twitch response jump sign. So by that we can evaluate that there is a trigger point. And for trigger point releasing also, we are having a direct myofascial release. We can use Cairo activator tool, where that also we can use for that to dissolve that trigger point. And we are having so many other agents by which we can release this trigger point, like the cupping or the needling also, or the ISTM. So these things, by that we can understand the how these trigger point can be released, and the muscle twitch can be normalized, and the taut bend can be released. So the patient will feel comfortable. They will not in the, their muscle will not be in the spasm. Their muscle is not in the tightness now. And after that, we are moving towards the neuropathic pains. That is also important part of our treatment as a articular myofascial. We cannot leave these nerves which are giving the stabbing sensation, electric shock like sensation, pins and needle, numbness, throbbing sensation, shooting sensation, and the burning sensation. So in this also, the neuropathic pain can be caused by many different conditions like alcoholism, diabetes, HIV, multiple sclerosis, joint problem in the spine, and it can also be a side effect of any visceral treatment like the chemotherapy. So because of that also the patient feel this neuropathic pain. And also the other structures can be the cause of the neuropathic pain, like the disc herniation, stenosis, radiculopathy. So that also can create a either the neuropathic pain at particular point or the radicular pain all along the course of the nerve also. So this is also we can also have a neuropathic pain when we just the phantom limb syndrome like condition. After that also that nerve feel the numbness on that part condition. So that is also burning type pain, or the numbness and tingling they feel after the removal of the limb also. So these are neuropathic pain condition where the nerve fibers, they are sending the signals that either the same side or the contralateral side also. So they feel pain on that area also. So this kind of condition, we know that it is also related to the central pain also, but the pain, radiating pain on that upper limb, lower limb, or at that particular point, or it is taken to all over the nerve, or proximal versus the distal symptoms are, proximal symptoms are more or the distal symptoms are more. So how the nerve injury is in the severity can give us the idea by evaluation of the Tinel sign, or we check the muscle nerve massage with the palpation of all along the course of the nerve, we can understand about the neuropathic pain. And in this also the pathophysiology of all the nerves related to entrapment neuropathies, which is structural, mechanical, or dynamic. In this also nerve injury, we divided into three classification: neuropraxia, extonomesis, and neurotomesis. In this also, where the only the conduction is loose, that is the, you can see it in there, sorry, in this picture, only conduction is blocked, that is neuropraxia, where the two axons are blocked. So these are the axonotomesis. And if there is a nerve is divided into the two part, that is the neurotomesis. So this kind of the injury and myelation, demyelination and the myelination is plays a very major role when there is a nerve injury, because of the blood supply through the epineurium, perineurium, and the endoneurium. So that plays a major role, either the interfascicular having a problem, or the patient is having the problem related to the nerve is not taking the signals, where the nerve is completely divided into two parts. So their signals are stopped, they are working destruction in between the two parts, they are divided into two parts, so they are not carrying the signals. So these kind of the condition, that nerve injury can be it's divided into the three classification. By that we can see the patient symptoms, what kind of the symptom they are having. So according to that we have to see that either how severe is the injury related to the nerves. So this is, you can in picture you can see that the how the epineural sheath. This is the epineurium. This is the perineurium, and this is the endoneurium. So there are the fascicles. So interfascicular dysfunction, and there, because of that, we see that the patient is having either they are having a slider versus the tensioner dysfunction according to the injury related to the interfascicular related injury. So the nerve is not getting the space. So this is either the nerve is thickened or the space is less. According to that situation, we understand when we see the neuropathic pain. And this also that this is the neuropathic pain caused by the dysfunction of the nervous system or damage of the nerve itself. And this is the nociceptive pain, which is the signals are getting through the nociceptors, the free nerve endings. So in this also, in the neuropathic pain is caused by the nerve damage, and while the nociception pain is due to the tissue damage. So as nociception versus the neuropathic pain, it is very clear that if there is a tissue damage, that is nociceptive pain. If there is a nerve damage, that is the neuropathic pain. So nociceptive versus the neuropathic pain differentiation is also important here. And in this also, if the patient is having a neuropathic pain, so observation of the legs and feet, so how their skin tells like the deformity, deviations, skin discoloration, skin breakdown, skin glossiness, vascularity, edema, nail bed atrophy, hair loss, which already sir has explained in our yesterday session in full detail, that how we can see as a skin observation with the legs and the feet, or in the hand, on the nails. So this is also that can give us a idea related to the with the neural symptom also, or same like with the autonomic dysfunction also. So these things are also matching here, that because when we talking about the peripheral sensitization here, or we are talking about the neuropathic pain here, so in this also, in between the symptoms, some symptoms are matching in this observation with the autonomic nervous system here also, that we see in our further slide. But the same we are, why I am highlighting, because when we see the patient with the autonomic nervous system, so these kind of picture for their skin we see in the autonomic dysfunction also, the sympathetic mediated pain also. And in this neuropathic pain, how important is the Tinel sign? Because positive Tinel sign is a good predictor for the positive outcomes following nerve decompressive surgery. And we see that a positive Tinel sign is associated with the distal production of the symptoms such as the tingling, numbness, and paresthesia or the diesthesia. So it means the manual percussion all along the course of the nerve, if it elicit any problem, the sign of the regeneration of peripheral nerves in the response to the minor or major injury. So when we give the percussion, we check all along the, suppose I am checking through the median nerve. So if I am checking all along the course of the nerve, so we can see that how much injury, if there is a symptoms are only at that particular place, or the symptoms are the numbness and tingling in my wrist. So according to that, the how much the nerve injury is there. So the distal part also getting the symptoms with the nerve injury, or there the numbness, tingling in the thumb is coming. If I am all along the course of the nerve, I am checking with the medial nerve, or the patient is having on only the particular one part, or they are having a proximal symptom versus the distal symptom. Proximal, where from that nerve root is coming, there the patient is getting a signal, or the distal. So according to that, we can see the severity. So it is important to check always when you want to check the neuropathic pain, the Tinel sign is always very important part. In this also, that sir has explained in our one session, that with the tuning fork also we can keep all along the course of the nerve, we can check that how much mechanical conduction is going on, and the how the intensity of the nerve damage is there, and the patient feel the pain at particular point if there is a nerve injury. So these things are important when you want to do the evaluation, like the articular myofascial we have checked with the mobile hypermobility, hypomobility, myofascial with the tightness. But when we talking about the nerve, how we do the evaluation, that is with the Tinel sign and the nerve massage or the palpation all along the course of the nerve. So that gives us the idea to their connective tissue layers or the interface of the nerve, whatever other structures which are related to the nerves, the articular versus the myofascial. So assessment of the interface also gave us the idea that either only the nerve is having a problem, or the interface, the other structure are the cause of my neural symptoms. So that can also give us the idea. So treating of interface versus the neural component is also very important here. And this is the pain pathway that we have already discussed, that how this nauseous stimulation go towards the brain. And this is the radicular pain, that is also like the neuropathic pain, the radicular pain all along the course of the nerve, and the pain is coming, that is the radicular pain. So radicular pain radiating like for the upper extremity from neck to radiates down into one or both the arms, it can go, or only one way. Or likewise, radicular pain from the low back radiates through the one or both the legs according to the severity of the nerves. Either there is a radiculopathy, either there is a stenosis, so the both legs or the spinal nerves are getting compression. So these cause you to the experience pain. It may be perceived as a tingling numbness, or in other areas your body, which is the organs which are distant to the real source of your problem, can be the cause for the radicular pain, from cervical to the upper limb, or from lower back to lumbar to the lower leg. So this kind of condition where the radicular pain is going, the cause is in the proximal part and the pain is radiating towards the distal part. So this is the kind of the sensation we feel in the radicular pain. So this is the causes of radicular pain, where there is a herniated disc, nerve root injuries, scar tissue from the spinal surgeries. So there are, or the foraminal stenosis, a spinal nerve problem caused by the bone spurs, osteophytes. So these are also the cause of neural radicular pain. So that also we have to see with the either the structures, the articular, which are creating a problem for the neural, like the interface we have talked about, that other structures are creating a problem for the nerves because they are not getting the space. There is a compression, there is a narrowing of foramen, there is a narrowing of the spinal cord, like a myelopathy condition. So that is also very important part here to see the radicular pain in the patient. So this is the radicular pain if the patient is like, I have mentioned it here, the cervicobrachial pain syndrome, where all along the course of the nerve, patient feel pain. Whenever we palpate, we do the checking all along the course of the nerve, the patient feel the pain. So this is kind of the radicular pain we see in the cervicobrachial pain syndrome. So that I have treated one of my patient where she was having the same pain. So this is the radicular pain all along the course of the nerve. And in this upper radicular pain for upper limb, that is also, we have seen that why the radicular pain is coming, because of the cervical radiculopathy, or there is a narrowing of the foramina. So the patient is having the C from C5 radiate up to the hand, the pain is coming. So it is radiating from C6 to 7 to the shoulder, the forearm and the hand. So these kind of the pain is originating from the cervical spine, and it is radiating towards the upper limb and as well as to the lower limb. So this is also the radicular pain, the lumbar radiculopathy versus the cervical radiculopathy, where we see that the patient is having a pain all along the course of the nerve. So the patient pain is coming till the foot, they are having a pain. It's like a condition, that is the radicular pain. The pain travel all along the spinal nerve root. So like the S1, L5, L4, L3, all along the way, from where from base proximal to distal, how these nerves are, their root values are coming, they are supplying. So this kind of the pain with the full nerve root value all along the course of the nerve, the pain will be coming. So this is either the some patient pain with the numbness, tingling, and they feel the muscle weakness also. So radicular nerve pain because of the compression or the pinch or inflamed or impingement, because of that the patient feel the pain in that particular upper limb versus the lower limb. And then we are moving towards that after neuropathic and radicular pain. Now we are having our last part where we have sympathetically mediated pain. This is also very important part, because how we see that either the pain is having a sympathetic or parasympathetic. While the sympathetic nervous system is designed to send out the pain signal at appropriate time to get the body ready for the action, that is the fight and flight and fright, which we have already discussed tomorrow. And the parasympathetic nervous system is designed to calm these signals, to relax the body when pain does not need to be felt. So the body is experiencing pain in as a effective. So this is the peripheral nervous system, when we talk about the in this also, that somatic versus the autonomic nervous system, where the involuntary function, visceral motor, visceral sensory, and after that there are the sympathetic versus the parasympathetic, where fight or flight, rest or digest. So this is the two terms which we use. As a sympathetic, they are always ready for the fight and flight, and the parasympathetic division, they just hold on. It's like two people in the home, one want to fight always and another want to just relax, these kind of the situation. So these are the things we understand about the sympathetic division and the parasympathetic division, which plays a major role. Like in our session yesterday, sir has explained that how the when the patient, they are having a overactivity or underactivity of the sympathetic nervous system. So like the parasympathetic, because sympathetic nervous system is overactive, so for that cool down, the parasympathetic nervous system take the place to cool down them. So this kind of the situation we see in some patient. Some patient are very highly uh, they just highly responsive, or they are very they feel aggravation is in the part of their life, and they just, by giving them a small tension, their heartbeat raise, or they feel breathless also. So these kind of the situation, we can see that how their sympathetic nervous system, and when we give them a parasympathetic treatment, so that give them the relaxation of the brain. As we know that that how the sympathetic ganglia from lower cervical to the lumbar, thoracic and lumbar, it is present, the sympathetic ganglia. So we can reach them through that sympathetic ganglia, or the parasympathetic nervous system, which is for the visceral organs, or for the upper cervical, or the cranium, where we use as a craniosacral therapy, where we relax the brain through the parasympathetic system, or the vagus nerve, which is already we know that is a fiber of the parasympathetic. So that also we can take in our picture if we want to treat the sympathetic mediated pain. So how we deal with the vagus nerve, which is also very important part of our treatment whenever we treat our patient with the sympathetic mediated pain. In this also, you can see it. The sympathetic mediated pain, in this the patient is having an intermittent symptom that is also mechanically provoked or aggravated. Symptoms are very different, closely associated with physical and mental stress, altered sweating, hair, local cutaneous circulatory disturbance, skin trophic changes, that we have already seen our in a picture of that lower limb or upper limb. We see that how the skin texture, temperature, sweating. So these symptoms are the part of the autonomic nervous system. Some people feel more sweating, some people feel some area feel less sweating. So these type of disturbances, or their nails, how we can check the nail bed atrophy, that is also the part of, or hair fall, or altered sweating pattern, or their like the vascular changes, arterial versus the venous, having or lightness in the cold, hot or the cold weather, that is also a part of the autonomic nervous system as a vascularity part, elevation versus dependent position. So this is also, and in this, the sympathetically mediated pain is very much taking the symptoms, which I realized that from some symptoms for the central sensitization, also some symptoms with the cognitive affective also, nociception also, visceral also. So these are the, this is the very important part of the treatment, because they are carrying all the characters of all the pain based mechanism. So we have to see that how we can treat if the patient is having a sympathetic mediated pain. According to that, they feel uncomfortable at uh, uh, they feel intermittent pain, sometimes they feel pain, sometimes less pain, high pain. So according to that, we can see that in which position they are feeling comfortable. There also we are having as a neural component, we treat them as a sympathetic, that's in the slump position, because we can reach towards the sympathetic ganglia through the sympathetic slump. So that type of treatment is very much useful for autonomic nervous system. And as a in AMPT we are having the full master class for this autonomic nervous system. There is a dysfunction related to autonomic nervous system, that is the dysautonomia. So there also we can see that how we can treat the sympathetic mediated pain. And you can see in this picture also that how the autonomic versus the sensory motor and inflammatory versus the psychological. So these are also the picture when we see the sympathetic mediated pain. And in this also the symptoms are very important. Sleep disturbances, pale hand and sprawling fatigue, heaviness in the hand, and in thoracic sympathetic some position, we can give the myofascial release on thoracolumbar fascia, and we can mobilize the thoracic spine also. So this you can see it here, and these are the major points, characters which we see when the patient is having a autonomic nervous system related problem. So the sleep disturbances are very common and are pale, glossy, shiny type. The skin nails are like a nail bed atrophy, and sprawling, warm sprawling, like fatigue, they feel fatigue and they feel heaviness. So this kind of symptoms are very, very common in the patient. So how does the sympathetic nervous system respond to the brain? So the pain stimulates the sympathetic nervous system, which in turn increase heart rate and causes the peripheral vasoconstriction. So the all the constriction means they are just narrowing, and the photoplethysmography, like the pulse oximetry, can be used to assess vasomotor tone, vasoconstriction, and the heart rate, and thus could potentially be used as a surrogate to assess the perioperative pain. So these kind of the things which we see that the vasoconstriction. So these are the pulse oximeter, and that is important. And when we see as a clinical, so we see that the pain impulses where the sympathetic respond to the vessel spasm increase the pain because of the vasoconstriction, and the pain in that particular injury start the cycle that they again send the signals to the brain, and again the sympathetic response is coming. In this result, because of vasoconstriction, the blood flow is restricted, vessels are in the blood area is very small, so the result is the burning pain and the swelling is coming. So this is the how the sympathetic system is uh, working when there is a stimulation because of the sympathetic response. And this is the dysautonomia, the when the dysfunction related to the autonomic nervous system. So which pointers are highlighted, which are the gives the stimulatory effect, and which are the inhibitory effect, that you can see that which are working, like the eyes are dilated, skin, their texture change, lungs dilates, heart working, heart rate is increasing, stomach, because heart rate is high, you cannot work for your digestion because that is the working of the parasympathetic, and the gallbladder maturation and all these, the bladder function. So these are also as a inhibitory effect. So these are the things as a, and we know that you can see in this picture very clearly that how the sympathetic ganglia which is present in the lower cervical to the thoracic and then the lumbar. So these organs which are coming in the part of that, they can be related to the sympathetic nervous system, and the parasympathetic where you can see that the upper cervical and as well as to the sacrum. So their stimulatory effect is on the upper cervical or on the sacrum region. So these are the things where it is working, and we can see that if there is a dysfunction in their symptoms, so dysautonomia is there. So we have to treat, we have to make the balance related to the sympathetic versus parasympathetic nervous system. So this is the part of all our pain-based mechanism with the cognitive to central sensitization to peripheral sensitization, and as well as the nociception where the somatic versus the visceral, then neuropathic, then the radicular pain, and then we are reaching towards the autonomic nervous system. So this is the part where we can understand in the 5 mechanism based reasoning of pain mechanism, and we can see that how these for the autonomic nervous system, the sympathetic slump plays a very major role, or sympathetic uh, in the sympathetic slump we can give the releases of the if there is a nociception, myofascial, articular joints. So these are the things also as a orthomyoneuromanual therapy we can add on that. So this is also very useful to treat the patient when they are having a autonomic nervous, the dysautonomia. So this kind of the treatments are very much useful. And then this is the pain scale which the people are made, but we working on the patient centered approach where we see that how we can improve the functional activity of our patient and according to the patient centered approach. That is the main focus of AMPT. And this is the pain warning, and with the destructive pain, how the tissue injury, non-stimuli, non-nauseous stimuli that causing the pain, that is the neuroplastic, neuropathic, and the nociceptive pain. If there is a tissue injury, the nociceptive pain. If the patient is having a non-nauseous stimuli is neuropathic pain, non-nauseous stimuli like the neuroplastic pains. In this also the tissue injuries plays a major role. Because of that, the patient is having a pain. So these are the characters which we see in the pain related classification. And after that, I think hopefully we are now able to understand all the mechanics, that is the pain-based mechanism, where we have worked on the central sensitization, cognitive affective, sympathetic mediated pain, peripheral sensitization, and the nociception. So these are the 5 mechanisms which we have now. More we will see in our workshop on the Saturday, where the sir will explain as a practical demonstration. Then all these theoretical part will be, I hope, will be more useful for all of us, so that it will be clear that what kind of the treatment needed for cognitive, what kind of the treatment is needed for the central sensitization, autonomic, or the peripheral versus the nociception. So that we will see in the our workshop, that is on the Saturday, for the advanced certification course for the nociception pain-based mechanism, how we can deal it if the patient is having a different mechanism, and how we can deal it differently or simultaneously with the mixed up the treatment. And these are the references. I have not taken any other references because these are all the articles of the Dr. Senthil sir, which he submitted in the PubMed as a research paper. And these are only few, but there were so many numbers for that articles that are very much helpful to see that article, how we can understand the pain on the mechanism based reasoning. That is very important part for all the physical therapists. So these are our way to learning about the pain based mechanism. With the help of these articles, they are very useful. Thank you so much, everyone. And thank you, sir, for giving me this opportunity to revise all these topics so that we can understand, and we will be more actively participate in the workshop where you are going to explain or through the practical demonstration. So till that, we have covered 6 webinars, the pre-congress webinar for the topic of pain-based mechanism. And in 3 days, we have covered the 6 webinars. That is the, I will say, the main highlighted point of the AMPT. In the very short time, we prepare ourselves as a theoretical part before the practical workshop as a offline. So now we have covered as the online part, and now we are moving towards the workshop. So thank you so much, sir, and thank you everyone. Over to you, sir.
So, Sujanya had asked a question in, vagus nerve treatments. You want to switch to the phone, ma'am? Or you want to go check and come back, whichever? Ritu, ma'am.
No, okay, sir.
Sujanya, you can unmute. Okay. Yes, Dr. Sujanya, you can ask directly only. What is your question? Vagus nerve. What made you to, yes.
Yeah, so just ma'am actually mentioned, how vagus nerve has a good effect. The the fibers that connect on the sorry, I'm half asleep. Did you say sympathetic or parasympathetic? I think parasympathetic. How that mechanism works when you release certain things in the cervical occiput, which course entails that? Because I would like to enroll that for future. So I just put the question there, otherwise I'll forget to ask later.
Actually, ma'am, whenever we see that the parasympathetic fibers like cranial, all the cranial nerves we are having, in this the parasympathetic fibers that carrying the parasympathetic fibers by the vagus nerve, because it is the longest nerve which is coming from cranial, from brain to the our full visceral organ, the digestive organ. So it means that we know that the parasympathetic slogan is the digest. You know that you treat your patient. So how, without treating the vagus nerve, you cannot treat the parasympathetic fibers of that particular area, because they are passing through the alimentary canal to the stomach, it is coming. So treating in the as a slump position, treating the parasympathetic fibers through the vagus nerve is very important if you want to give the best healing for the, if there is a patient is having a indigestion, patient is having a visceral organ like the any liver related problem, any stomach related problem with the abdomen, intestine. So we can reach there through the vagus nerve only by keeping them in the slump position, and then we know that the for the visceral organ how we give the pressure. So here also, because it is carrying through the full alimentary canal, so we can treat it as a proximal versus distal part. On which part we want to treat that? Suppose I want to improve the digestion, so from the digestive part I can give as a proximal part, I can take the esophagus, and that distal part I can take the that area, that stomach or maybe the gallbladder or whatever, sorry, intestine. So there we can give the pressure as a visceral organ on the vagus nerve and keeping them in the slump position. Why the slump position? Because we are taking the dura in between the picture, keeping in the slump position. Like we give the slump, sympathetic slump position. So we give the patient in the slump position. So then treating the vagus nerve is very important, because there is a plexus of vagus nerve is in the alimentary canal. So it is coming out from there, that plexus. So from reaching for improving the digestion, for improving the parasympathetic activity is very important to treat the vagus nerve. If you are treating your patient for the parasympathetic, so without treating the vagus nerve, I think, if my understanding say, you cannot treat it fully, because it is the part of parasympathetic. So treating the vagus nerve is important, because you know the upper cervical, you are treating the patient of the craniosacral. So that is also related, upper cervical to the sacrum, as you treating na, because of parasympathetic overactivity, or sorry, parasympathetic fiber. So for the stomach, for the digestion, without treating the vagus nerve, we cannot reach it. If the patient is having even a problem related to the swallowing or the speech, then also we can, because that is also again the vagus nerve is coming in the picture. So we have to work on that. And which my understanding, rest the sir will more highlight on that point. Yes, sir.
No, her question was which courses, okay, which courses cover the vagus nerve. Okay, if she wants to learn about vagus nerve treatment and physiology,
okay,
which courses she has. Okay, so you can list the 7 courses. If you remember all the 7, yeah, go ahead.
That cranial, osteocranial, manual therapy, cranial nerves, we can take visceral, that VSMT course. There also we have worked on the vagus nerve, or even our pulmonary rehab also we have going with the vagus nerve. So these are our even 1, 2, 3 osteocranial, cranium, visceral, and which one?
You have the neuro course,
on and autonomic nervous system and dysautonomia. There also we have seen the vagus nerve. So where we have to work on the autonomic nervous system, there we have to learn about the vagus nerve. That all the courses, either on the neural, the neuromanual therapy, that is also because we treat the patient in the slump position. So there are so many courses. Maybe this time I am not able to connect, but 4 or 5 I have remembered. So
Yes,
that
yes.
courses you can take and you can learn
Sure,
about
sure.
this Vegas now.
Yeah,
Yes,
yeah.
ma'am.
Because if it is the focus is only Vegas now, it is the 12th, what is the Vegas accessory hypoglossal, 10th cranial.
10th cranial.
So 10th cranial now. So cranial neuromanual therapy. That is the direct course.
Okay.
But if you think that the patient as a whole, I have to understand means Vegas, the outflow is from craniosacral and sacral. Craniocervical and sacral. The parasympathetic outflow. So you need to do the cranial course, the cranial osteomanual therapy. Or even pelvic manual therapy specialist because sacrum dysfunctions. Okay.
Correct.
So that way. If you want to
Okay.
address the dura matter, whether neuromanual therapy, which is combining with thorax, like how Madam has told about respiratory, pulmonary, visceral manipulation, because visceral manipulation, visceral treatment itself is parasympathetic. And all the viscera are supplied by the vagus only. Okay. Also, left side vagus is longer and more extensive than the right vagus. Okay, right vagus is half only the size of left vagus.
Okay.
But still, and then dysautonomia specialist is specific to the autonomic nervous system, in which sympathetic and parasympathetic both are coming. And we had like a pathomechanics of nerves. In that, the third module, we have a spinal cord pathomechanics, meninges pathomechanics, and the autonomic nervous system pathomechanics. So we have in that the ganglia, where all it is there, and how the mechanics actually gets influenced. Okay. So pathomechanics of nerve, like joints and muscles, separate module. Nerve is also having 3 modules: upper limb, lower limb, and the spinal cord with meninges and the autonomic nervous system. Okay.
That will be interesting to learn.
Autonomic nervous system is part of why visceral manipulation, because viscera is parasympathetic. Why it is part of even a cranial base release or suboccipital release, what you do, it's a parasympathetic treatment. Because upper cervical, you give a manipulation also, the atlas axis, that is also parasympathetic. Okay, because cervical outflow is parasympathetic. Spinal manipulation, you may think like that, or it is cranial method like occiput you want to treat. The spinal basilar junction, definitely that also becomes parasympathetic. And breathing, rapid breathing versus deep breathing, sympathetic and parasympathetic. How alternate nostril breathing are influencing the sympathetic chain using a combination of breathing and thoracic cage manual therapy. Okay, rib techniques, intercostal techniques, and spinal mobilization, spinal manipulation, thorax. Okay. You can actually calm down the sympathetic nervous system by treating the thorax. Okay. Because we say that parasympathetic, if you want to focus vagus, you have to see that why you want to focus on the parasympathetic. That means sympathetic is excited.
Exactly. Yeah.
That is the only dysfunction. Our sympathetic is diminished. So that is the only problem. Parasympathetic is not the primary. Okay, it is the effect of sympathetic dysfunction. Okay. If pain, we are feeling too much of pain every time, parasympathetic is diminished, we cannot tell. Okay, it's sympathetic which is activated. Okay, so that is the reason why we feel pain for everything. Okay, so that's why these two come in balance. And there is a dysautonomia course where sympathetic and parasympathetic, both the sides, how effectively you can engage them in treatment techniques like that. So there are various aspects which you can focus. Okay, viscera manipulation is a big one. All the visceral techniques is parasympathetic. Okay, so you can use it depending upon where the related area the sympathetic dysfunction is there. If I have a neck related sympathetic overactivity, I can use visceral manipulation with the tongue or the esophagus or the trachea. Okay. So the related somatic region, the sympathetic disturbance which is there, here parasympathetic will give tremendous relief.
Mm-hmm.
But if you want a long-lasting relief, you have to minimize the sympathetic, for which you will use cervical slump or the thoracic slump, the sympathetic slump, or thoracic spine-based treatments, because that is sympathetic origin. So you can't just learn only vagus and then move on with as a treatment. You need to do that lowering the sympathetic one. Kind of any exercise training which is more than 6 months, if a very good adaptation comes, means sympathetic nervous system will be kind of minimized. Okay, it is not going to be alerted hugely. You develop the best pain tolerance, increased pain threshold. Okay, because people who are going to the gym also. Okay, all this. So that is sympathetic conditioning or adaptations. Right. So nothing is going to happen. See, the fact here is, you see that all the courses you take, or which course I can take first. Okay.
Yeah, it's all interlinked actually. It will all overlap.
If you see that like a big kind of a bull bulaya. Okay. And after that, if you see that simplest what I can do, okay, cranial nerve I can take. But cranial nerve also, vagus is not separately available. It is like all 12 nerves.
Yeah. Yes.
And vagus
That's
also
okay. It is good to because it's connected in every course. It's interlinked. It makes complete sense where where all it touches, which areas and which courses. So there's no harm in doing any of these courses.
Yeah, there's no harm, but sometimes you will feel like your vagus now will become atrophied. Okay, totally you are doing kind of a learning which is like beyond the human capacities. Okay, all at one shot, or you feel like I am not able to watch the videos. Okay, or I am not doing anything like that. That feeling will come. Okay, so
yeah, I'll do one at a time. So that would be the next one to take, though, after my commitments I have all the courses I've done so far.
It's like Ritu ma'am, you ask like when is her work gets over? Okay, impossible. But she kept that 2 hours. This is for me, like that. In the beginning, when she had a huge challenges, okay, you will know that it is like you have to alert. You know that, for example, whenever you don't give any appointment in the clinic, for example, it is post lunch or anything, okay, where people will be less, the visiting patients, and watch the videos during that time. See, you can't get an extra time in the evening, because evening is family, children, all your what to say, attending is okay, it's possible, but watching a video in the evening is not possible.
There's so much distraction. It's unbelievable.
Evening is certain time of the day. Okay, why will we be, it is like kind of just with the video, why will be, but watching live means we'll think like people are there on the other side, so you will get that
more interactive and interesting to tag along.
Especially like you at the end of the day, when the parasympathetic is waiting to take over. Okay, so that time, if you are still prolonging, okay, keeping the sympathetic nervous system like it is like the horses and the things in the Kedarnath, Badrinath, and the Vaishno Devi, okay, temples, where the horses are like totally like weak and climb, but these people, they twist the tail, okay, and make the horse to go up, okay, and they charge us triple, okay, 1,200 rupees. He charged me 3,600, okay, and he made sure that the horse will climb in the evening, but already it would have done 5 trips, okay. So these kind of things to sympathetic nervous system also, we cannot keep on pushing. What happens if you push? The sympathetic nervous system stays there right up. It will never come down. Okay. It's a principle of overload. Okay. So we keep pushing. So yeah, madam can go. And so the parasympathetic is never able to take control of it. Okay. Or bring the system back to the rest. And sometimes you will find that when you lie down also, you will not get the sleep. Okay. You might get now sleepy, but when you lie down, you will not get the sleep.
Yes.
Understood? So the thing, because here is an indication that sympathetic is overwhelmed or it is overloaded or fatigued. Okay. But when you go there, the parasympathetic is not ready to take over because at rest, how much the sympathetic nervous system has to be there. Beyond that, the sympathetic nervous system will be double when you're lying down. So you'll be checking the phone or you'll be like
I better
talking.
leave it here.
Yeah.
I'll leave it on the desk and I'll go.
Something or the other, you will be like checking, or you'll be watching maybe some learning videos, anything, which is in the social media. So here and there, you may try to respond to emails or respond to queries from anywhere if it has come. So all that. Understood. So it's very tough. That's the reason why we tell that kind of even a posture, when you tell that slouching posture itself will make the sympathetic nervous system to be activated because thorax is that elongate. Okay, sympathetic ganglia, everything will be sensitive. It will not get desensitized with slouched posture over a long period of time. Never. Okay, it is not like somatic nerves. These are autonomic nerves, and they in turn affect the immune system. That's why thoracic spine manipulation is useful even for dysmenorrhea. Okay, because dysmenorrhea is part of a sympathetic activation disorder. Okay, so irritable bowel syndrome. Okay, a lot of pathologies were treated with thoracic spine manipulation.
Yes.
Right, so we are ready to say bye-bye. And tomorrow is the journey day, and we'll have the course day after tomorrow, the pain mechanisms and nociception.
Saturday.
And of course, the Sunday is the medical acupuncture. Okay, so that's a different total domain, but that's also dependent upon the pain sciences. That is taken by Shatab sir. So we have this for the weekend offline courses at Chennai, 29 and 30 at the Malayali Club, Chennai, India. Right?
Yep.
So see you, bye-bye, and good evening
Thank
to
you.
everyone. Good night to Dr. Chujanya. Okay.
Thank you everyone. Thank you, Ritu ma'am. She left already.
Yeah,
All right.
she has to go with her mom.
Okay. All right.